So, hi everybody. I'm Terri Conneran with KRAS Kickers, and clearly I wasn't paying attention to what was going on in my screen, and so I apologize. But welcome, and I'm really glad that you're here with us today. I'm an 8-year lung cancer survivor. Started the KRAS Kickers group almost 5 years ago, and so that's who we are and what we do. I'm delighted today to welcome Dr. Colin Lindsay. I'm going to read you his bio. He is a clinical senior lecturer in medical oncology, also working at the Christie NHS Foundation Trust. He divides his time 50-50 between research and the clinic. He's trained at the Cancer Research UK Beatson Institute and Cancer Center in Glasgow, where he completed a PhD under Owen Sansom, studying genetically modified mouse models of RAS and RAF-driven melanoma. Following that, he shifted his focus to lung cancer translation through involvement with the Stratified Medicine Program, as well as a 2-year ESMO Translational Fellowship with Benjamin Bess and Jean-Charles Soria, and I am destroying names one after another.
No,
At Gustave Roussy Institute in France. His main research interest is in the translation and implementation of effective treatment strategies for cancers driven by RAS mutation in the MAP kinase pathway. And although I know that you're kind of considered a thoracic, okay, a lot of the application is very much like cross cancers. But, and so if you're not necessarily with lung cancer, do stick around. I need to make sure I thank the sponsors that have been able to be with us today, which is Jen and Tech Roche, and with Veristom. And I am delighted, Colin, to have you here today because we've gotten to know each other over the past couple of years at different conferences. So welcome and thanks for being here.
Delighted to be here. Thank you, Terri, for inviting me. I'm humbled and honoured to be here genuinely because you are an incredible advocate for this topic, and it's a pleasure to share what we're doing.
Okay, well, I'm going to let you just kind of set the stage and do your slides, and if you're okay, I'm going to interrupt as questions come up. Anybody that does have questions, please hit us up through the little chat bar there, and so hop at
it. Great. Okay, so feel free to jump in whenever you want. I probably prefer it that way, that we have more of a conversation. I appreciate speaking to the international audience. I do think I have a Scottish accent that people mostly understand. I hope so. Yeah, you're nodding your head, so fantastic. So just this is the title of my talk, but it's quite a wordy, sciencey title already, isn't it? So I will try and break things down as best as possible, and apologies in advance if there's some terminology. I'll always try and explain that. Clinical senior lecturer, if anyone's wondering, I think it's just the UK equivalent of an associate professor broadly. So that's roughly where I am with what my status is in my post here in Manchester. And Manchester, along with University College London, they are partnered as the main lung cancer centres in the UK. So one of the reasons as a Scottish person that I moved to England was to really focus on lung cancer in particular. But as you say, I'm very interested in general, certainly with our preclinical work in RAS mutations in general, completely agnostic of which tumours we're considering. So just so people know, these are my disclosures. This kind of collection of buildings here is really what all the buildings that are involved in our cancer centre in Manchester. You can see a number of them now, and where we are situated is the northwest of England. Now, I've got a feeling that some questions will inevitably come up about how our health system works compared to the US system. I don't know, have you had many international speakers before?
Yeah. Well, yes, but because we're just we focus on the science and the research and kind of the actual part that really impacts the patient as compared to the differences in insurance and getting things covered, and kind of let people deal with that part on their own. And so Not so much. We've had different people come in from like Italy and whatever, but
Okay.
so with local differences, yeah. But I already have questions. I'm just chomping at the bit to hit you up with. So don't
Okay.
you worry.
I'll try and finish this slide
No
and then
worries.
we can get to it. Yeah. So what are the points I'm trying to illustrate here? Well, first of all, well, the sun, as some people will know in the UK, the sun and the rain is generally happening at the same time, 4 seasons in one day. I like that part of this picture. This is a brand new building we have, which I'm sitting in just now, which we call the New Patterson Building. And about 10 years ago, the old Patterson building, which had the Cancer Research UK labs, actually burned down. And so we had to completely rebuild the main building and our institute that delivered research. And I do think it's a really unique place to be because within this building, we have hospital researchers, we have university researchers, we have trial researchers, we have Cancer Research UK researchers, all from different disciplines within the one space on about 7 different levels. So it's a really fun and dynamic place to be. The other reason really just for showing this is that we have a national health service in the UK, and that means care is generally free at the point of access, and it's paid for upfront in taxes. And what that means is more than any place in the UK, Manchester describes itself as the largest single site cancer centre in Europe, and that's because of patient volume, unfortunately. And so this is part of the Christie Hospital you can see here. And what it means is that there's still not enough choice, arguably, in the UK. And so if a patient is fit and has a KRAS mutant or a MAP kinase pathway mutant lung cancer, then they're generally going to come to my clinic at some point. And for a catchment area of over 3 million people, about 1,000 to 1,500 new lung cancer patients per year. That's quite a large volume of KRAS mutant patients that we see. So I'm going to tell you how we've tried to turn that unenviable position into a position of advantage by taking as many samples and using all the data from these patients as much as possible that we see. Then I'm going to just try and show you how we started to apply that experience to one of our stories that we recently published. I know, Terri, you've seen this before, but yeah, we've had a very close look and been able to have a very close look in lung cancer at how G12C compares to G12D. And then, yeah, I'll just move on to final points and challenges for the future. But we do have similar stories coming through. Unfortunately, it was just a little bit early to tell you our next story, which we're probably going to submit in the next couple of months, but I'm looking forward to updating on that.
That's okay. You can come back when it gets interesting.
Yeah, thank you. And the principle I tend to come back to with all of this, this is Baby Gerald in The Simpsons, and Maggie Simpson always had one eye on Baby Gerald just as her enemy. And I think you will probably see, and I know you've discussed how there's almost this dizzying array of different medications and how to process all of that information. And I find it difficult to process it as well. So I kind of prefer this principle of trying to move to a point where we're shaping drugs more to cancers rather than trying to find a fit for cancers with drugs. And I think probably we're still going too much it should be both directions, but I think probably we're still not doing it too much we still need to know a lot more about the cancers and then create the drugs from there. It still feels like we're trying to find a home for drugs or not designing trials in the right way just because of lack of information partly. Okay. So you mentioned in my introduction that I do this 50-50 job, and it's genuinely a really privileged job, and most of the time, if it's not too exhausting and it's very exciting, and so I guess communicating with both scientists who are non-clinical and clinicians and trying to find middle ground with them is always a very interesting part of my job. And if I focus on the topic of RAS precision medicine, what I would describe as top-down research is that sort of reverse translation that we talk about when we're taking signals from the patients. It might be clinical trials, it might be just normal clinical practice. And we're taking those signals and we're trying to understand them better in the translational space. And then we're maybe going back into the clinic. And then, of course, really the revolution in RAS has come from, fundamental biochemistry, biology, and that's your traditional bottom-up model when you're looking at cell lines, mouse models, thinking about the chemistry of the different inhibitors that we're looking at. So, I'm interested in both sides and everything with RAS in the middle of my head, basically. But if I were just to briefly allude to the sort of topics that I think are still a bit further away from the translational sweet spot, I think this issue of immunotherapy combination toxicity with KRAS inhibitors, I'm not sure how much I understand it yet, and it's still definitely a very challenging issue in the clinic, and so that's why I raise it. Can we have better preclinical models to understand why that is happening? Because it definitely, I've seen a patient today, just an hour and a half ago that might have had an issue like this. Monotherapy toxicity, I think we frequently don't advocate enough how demanding toxicity can be for patients. I think I've heard you say in the past, Terri, about grade 2 fatigue and how impactful that can be. Grade 2 anything actually is generally often very impactful in patients, but we don't count it as serious within clinical trials, and so it doesn't necessarily get the attention it still deserves. And so having models within their known limitations that can better represent toxicity is going to be always continue to be important. And then, of course, having models in the lab space that represent the metastases we see, the organs that are affected by metastases. I think our scientific colleagues are getting very close to simulating that better. They're removing primary tumors from animals and then waiting to see where the tumors grow again. We have models here of brain metastases for small cell lung cancer, for instance. And I think that is something where we're closer to hitting this sweet spot. Now, the bottom-up research, which I'm trying to sort of impart still on clinical colleagues, is just anything about RAS cycle biochemistry and how that can still be important. Because RAS mutations such as G12C can still be vulnerable, can still be receptive to upstream signals. I think oncologists don't necessarily always appreciate that you can hit your target upstream. They just kind of might sometimes think certainly that the mutation switched on means you always have to go downstream with your targeting, which certainly with RAS isn't necessarily always the case. And then I think, again, just getting a bit closer to being widespread amongst the clinical community is that they do know, we are starting to, as a community, starting to appreciate that on-state inhibitors may well be fundamentally important as opposed to the GDP off-state inhibitors that we're currently using in the clinic. The translational sweet spot where I think we align quite nicely is that, of course, we see heterogeneity of response in patients with KRAS inhibitors just now. And that's what we saw in, that's what we saw in G12C cell lines when we did the original studies before we moved into the clinic. So that heterogeneity is there on both sides. Immunotherapy combination efficacy, well, definitely there were immune proficient mouse models that suggested that that immunotherapy plus G12C inhibition was going to be a very nice combination if the toxicity is manageable. And so the efficacy seems to be without question on both sides. And then I think insofar as knowing that G12C inhibitors would probably have a large therapeutic window because they're only meant to hit cancer cells with G12C. I think both sides, have kind of anticipated and aligned in terms of predicting monotherapy toxicity to a reasonable degree, I would add. So that is kind of a breakdown of my sort of assimilation of both sides and how I'm trying to sit in the middle and steer it all with the research that we do. This is the summary that I probably originally just wrote in the back of an envelope or something like that about, what we want our ambition to be in Manchester as, I think, a translational lab, not a core preclinical lab, and not a core clinical trial space, although you'll see we have a number of clinical trials in a second, but sitting really in that translational area to try and bring together both sides as well as we possibly can. And so I'll just point out the arrows here again, which just sort of denote this is top-down reverse translation compared to the addressing things with the bottom-up traditional model of research. And what we want to do, and you'll probably have heard me say this, Terri, is it's nothing novel. We want to we want to run the leading clinical trials, the most exciting clinical trials. We want to define new therapeutic vulnerabilities and resistance mechanisms for these cancers. And this is always a bit of a longer term aim that will take us longer as well. But understanding, possible preventative stories in the future with KRAS and RAS in mind. And I think that begins with understanding, why melanomas have NRAS or codon 61 mutations, why pancreas doesn't have G12C. We just kind of glibly say, it's to do with smoking, but there's something more fundamental going on, we think, that we're looking at, and hopefully we'll be able to report on in the future. The practical point is this one, and I do like sort of practical, non-intelligent questions that plays to my strengths. And basically, the practical issue is that we have so many drugs now already, direct KRAS drugs, and then all of these ancillary pathway inhibitors, that if you were to run all of the trials with all of the possible combinations, empirically, it would take decades and billions to do that. And so we need, coming back to this point, which I'll show you, biobanking, we absolutely need patient-based preclinical models, patient-derived xenografts, or whatever we can think about, maybe organoids more in the future for lung. They exist already for colorectal and pancreas more. We need those models to try and define the best combinations, but also we need them to better select patients for our trials as well. And so that's kind of the driving force, I think, of what we do. And these guys you can see here are basically the PhDs and postdocs that we have in the lab, and many of them are actually clinical trainees that are doing a PhD. You haven't interrupted me so far. I'll just keep going. That's
okay.
Right?
You're kind of setting it's okay. I'm just laying in wait. But no, I haven't. No, you're kind of like laying out the land and everything. And so I was just going to kind of let you keep rolling with it. Because we already have questions posted, but I want to kind of let you kind of get there, rather than just spitting out questions. So Liz and Steve, I see your questions, and we're gonna get to them. I'm letting him kind of set the groundwork up in order to kind of better hit it, so it's not doesn't come across random.
Yeah, and do you? I'm going slowly, right? So do you have a time?
I'm good. I'm following. I'm following along, and we have a. Yep. I got to tell you, we have a really smart group of patients, and so
I'm sure.
Yeah. So you'd be surprised. I learn stuff from them every day. It's utterly amazing. So no, it's you're tracking really well, and we're just out there trying to figure out where we fall within this, and so just have at it. I promise I'll interrupt soon.
Okay. Anyway, looking forward to it. So I know you guys speak about trials quite a lot. So this is actually my one slide summary of our trials that you can see that have either been past, present, or future. And some of the biomarker stuff is probably not an exhaustive list because there's lots of biomarker studies that we do, but some of your viewers may have heard of TRACER-X, which is the sort of heterogeneity studies we do, and is like a Cancer Research UK flagship program that UCL and Manchester lead on. ChemoRes is actually a small cell biomarker and biobanking program that we do. But what you can see, again, I think represented is how many patients we have. These are just lung cancer trials that we're running in our one centre. So at any given time, I think for lung cancer trials, we probably have about 20 to 40 trials that are either in setup, running, or closing. And just showing, the red stars basically show that we're doing well in the UK because we're the leading site for all of these trials that you can see with the red stars in the UK. I think what we're working on and what takes a bit more time with KRAS drugs is actually doing what we call, well, they've got various names, but the investigator-led studies, the academic trials. Most of the trials are still commercially driven. That's not really unexpected because, these drugs and assets are so exciting, and so they're very well protected. I think we will probably reach more of a tipping point in the future where we will see more academic-led studies with ideas that may come more from hospitals and research centres. But this is the main one that we're involved with just now, which is called ADEPT. Is actually just the simple question of looking at adagrasib, I call it adagrasib, in performance status 2 patients. So patients that were slightly less fit than those that were seen and recruited into the Crystal studies. And it's just a monotherapy study, a single arm study for lung cancer patients. So we're always looking for more investigator-led academic studies, but to be honest, we're really excited to be involved with, so many of these studies have been involved. So we have SunRay-01 coming up, so first line immunotherapy combination with olomorasib, which is a Lilly G12C inhibitor. We have, unfortunately, one I think real way we unfortunately don't see drugs in the same way as you guys is still with PanRAS and G12D inhibitors. And so this in the UK, I think, is going to be our first sighting of a PanRAS inhibitor, the RevMed second line lung study, which will compare with docetaxel in a phase 3 as standard of care. Apart from that, nearly all of these studies are still G12C based. And so it's an internal conversation mainly for the UK, how we get better at hosting the most exciting drugs, including KRAS inhibitors, such as G12D and PanRAS and pan-KRAS inhibitors.
Okay, well, I will interrupt now.
Yeah.
You could kind of anticipate, you'd feel the heat kind of build up. Okay, so if there's trials, do they actually have to go to that facility, or are they available at other sites as well?
Yeah, so I mean, if I take the examples of the current ones, I think this phase 2, I think it will be in a small number of other UK centres, and it's being run in Europe as well. Crescendo is the one, and a very exciting one, I should add, which is coming up, which is comparing divarasib to adagrasib and sotorasib. So that will be international. And then, we have Crystal 7 running as well just now, which is the immunotherapy combination, currently here in PD-L1 high patients with adagrasib, and again, will be international through BMS. And so it depends on the study.
Okay. When is the Crescendo opening? Do you know?
So we've opened here, and I think we're the first site in the UK, and we may well be one of the first, in general across the world, because I haven't seen too much information come through in Crescendo yet. But yeah, I think we are interested in it because there's so many G12C inhibitors now that having access to divarasib, and for that matter olomorasib, I think is going to be an important step. as well as the on-state inhibitors.
Okay, yeah, and it's kind of interesting to watch how they're kind of like breaking out. It's still the United Kingdom is still a smaller area than the U.S. is so spread out, and then comparatively speaking. So but you guys have already opened the RevMed drug trial.
No, I think so. This is a future one, so I think that will probably be Q1 next year. And the way this breaks down, I think generally is, and this is my perception, someone listening might want to correct me, but I do think it comes down a little bit to where which country your companies are based in. And so demand is there for these drugs. And so if you can run a phase 1 to 2 clinical trial quickly without leaving your country, then you do that, because that leads to a quicker and more cost efficient answer. For phase 3 trials, that's usually much more difficult. So we do see these drugs ultimately for phase 3 trials. We tend to see them more, at least in my experience, we've tended to see the phase 1 to 2 trials more when it's been, a European company like Boehringer have run a phase 1 trial for, and also, AstraZeneca actually used to have their headquarters in Manchester, so there was always a link with AstraZeneca here, but that's less the case now, and they're Oxford based now.
Okay. And then, since we're talking so much about G12C, okay, this is a good point for me to ask. Are you guys doing biomarker testing that's like full panel, or is it only specific to like G12C or EGFR? Can you explain how you're laying out your biomarker testing?
Yeah, and this is probably the main point that I thought would come up, and because I think it's this
we
sort of.
We don't need to worry about who's covering what and whatever, but just kind of like the standard practice, because
it's kind of this
being baited, Colin. I'm going to warn you, you're being baited. So go ahead.
No, so private practice is still a minority of patients here, and so what ends up being the case is that we're kind of spread thin for the majority of patients that come through the National Health Service, and so we are in this kind of frustrating position where we only get reports from 5 to 10 actionable changes for patients that we perceive to be treatable. And that will be the case even if they've had a 200 plus gene panel run. And so the resource is kind of diminished at the level of interpretation. They've actually had the panel run in their tumor, but they don't have enough bioinformatic expertise. We don't have enough bioinformatic resource to read out the whole panel. And so it's just done in a dedicated way for those 5 to 10 genes or changes or alterations that we think are immediately implemented. It's something that we can immediately implement in the clinic. There is a little bit of variation as well. So I think, if you had someone from the Royal Marsden in London speaking, I do think they get a little bit more information than we do in the majority of the country receives. So all these things that you talk about all the time, like STK11 and P53, we don't routinely get that information. And I guess the argument is, until we do the trial that shows definitively that it should change your treatment, then that information is useful to have, but not essential. So I'm not saying I necessarily agree with this, but I guess the point is, if you see someone with an STK11 mutation, because there's not necessarily a multitude of alternative treatments that you can turn to, then you would probably still give that patient immunotherapy, because we know it's such a good treatment. I think it's not really a desirable position to be in, but we've kind of forged a way in terms of practicality. And if I think about, I've got a colleague in Prague who's a friend, and often you realize that other countries end up in the other scenario, which is that patients have a full profile for their cancer reasons, Whereas, yeah, with us, it's the other way around. We can access the treatments generally, and the NHS has actually been quite good in recent years for allowing us access to fundamental treatments. But the profiling we get is limited, unfortunately.
Wow. And so the patients don't automatically get a copy of that report then at all? Or is it the only report
No.
that I've seen? I saw specifically. I saw somebody had had shown their report, and it was shown that they had a KRAS mutation that was not G12C. And I don't remember exactly how it was phrased, but it was like, so that kind of led me to believe that it was through NHS. It led me to believe, and so this is a huge presumption on my part based on one piece of information, one piece of data, that they're doing the testing and just basically ruling in or out. You are G12C or you're not G12C, and probably I assumed like a few other actual biomarkers, like I don't know, ALK or EGFR or what have you.
Yeah, I think that's probably the line of thinking which we do need to move away from. I mean, if I think, sometimes I try to describe the logical progression of this. And so in 2000, 24 years ago, we described the first genome that took, decades and multiple millions. And now we're taking hours to do genome for £1,000 or dollars. And so if we appreciate that scale of progress, then it feels a little bit short-sighted that we're not planning the same way with patients, and it's always piecemeal, this approach, where we're just like, okay, there's a new drug for that gene, so let's change all our systems again, and add on that gene to our what we call our test directory, so that gets tested properly now. And some of it is about anticipating and advising as best as we possibly can. It does mean, that generally, like I say, all patients get access to some sort of baseline. It's not easy. It's not an easy system to work within as far as that's concerned.
Okay, I probably could go a lot of ways with that. It seems like it might be more complicated to come up with like ideas as far as being able to do clinical trials that are kind of like outside of the box around that than limiting you there. Would that be kind of accurate?
I think that's a good point. I think, for instance, it means that we rely on central testing. As you guys will know, you can often, clinical trial protocols will often allow you to do local testing with fundamental changes such as G12C and sometimes in plasma as well. But if you don't have a regular, that means that you will have an additional week or two maybe to send your sample off for central testing. And then the follow on from that is that there will inevitably be a small percentage of patients that could deteriorate in that extra time while they're waiting to go on the trial. You're on mute, Terri.
Sorry, I'm going to hit these questions. I'm going to hit a couple of these questions that we started, and I'm going to do them out of order, because you were talking about the pan-RAS inhibitors, okay, specifically. So, what have you actually seen the efficacy of how they're working at all, or do you have a take on that from the G12, G13, Q61 mutations on the pan-RAS inhibitors?
Nothing beyond what's been reported. But I can reinforce the point that it's very exciting to us as a clinical community. So, not least because, the fundamental point that it's a bit more of a one-size-fits-all approach, so it could impact so many patients beyond patients affected by KRAS G12C. The toxicity that's been reported, mainly from ESMO last year, is impressive and wasn't anticipated. I think everyone felt like RAS would be more, or is a more fundamental aspect of normal cell physiology and cell biology. And so I don't fully understand why these drugs aren't so toxic, because I anticipated that they would be more toxic. But as many of you guys will know, the main toxicity that's come through is skin toxicity. Generally, that's something, although again, I would start by saying we underestimate often as doctors patient impact of these side effects. I think what probably the medics think is at least it's not a side effect that's normally associated with life-threatening problems compared to pneumonitis or colitis or something like that. That's our relative reference point. And so sorry, I'm just doing this sort of called the fully open version of everything. But yeah, skin toxicity is something that we can manage, and we have plenty of supportive medications to help with, and everything else.
Well, and honestly, when you have skin issues, it's glaringly apparent, as opposed to like fatigue. It's not like I've got an empty tank laying on my face, and so you get a little bit more sympathy based on it.
Yeah, no, that's a really good point. Yeah, and those sort of almost things that are almost too obvious to say sometimes are always worth reminding doctors about first and foremost. But yeah, I think as you've suggested, we have the potential now from the data, preclinical data as well, to hit G12D and G12V. And it was mainly the codon 12 mutations that showed promise in the clinical space too. From that trial from RevMed that I put up in the slide there, at least as I speak, I think there's plans to recruit the other codons affected by KRAS mutations, KRAS codons affected by mutations as well. And I think the excitement is very much genuinely there with the toxicity reports that have come through. And as you guys will know, the next step is to do the immunotherapy combinations. And the last thing to say is that for anyone that hasn't seen it, there was a press release from RevMed just in the last 1 to 2 weeks, which from memory, particularly mentioning the lung cancer results, it probably suggested two main things. Firstly, the immunotherapy combination was tolerable, so they're moving into later phase. But also, the response rate for the monotherapy was, from memory, 35 to 40%. But actually, compared to sotorasib and adagrasib, which had a similar response rate, the progression-free survival and the overall survival was more impressive than what I might have expected. So the median progression-free survival in the press release was, I think, 9 to 10 months, and overall survival pushing over a year. And so that, for adagrasib and sotorasib with the same response rate, it was more in the line of 5 months. And so the efficacy data looked better as well as the toxicity data. But I would add, as a fully trained and signed up medical oncologist, we do need to see the data ourselves. So I don't really like this trend of press releases now. I know that they're there for investors as much as anything. I want, ultimately with any company, I want to see the data in a meeting, in a paper, so that we can critique it ourselves.
Oh, for sure. And at the same time, dumb money, and being able to explain it to a dumb money means me as a dumb patient, I can understand what it is that they're saying in big leaps, even though I may not be able to understand, a swimmer's plot and how that actually applies to me as a patient. So I think taking all those different pieces into it is real helpful for us as patients.
Yeah. I think, I guess a general sort of piece of advice I would have is don't be too carried away with waterfall plots. I mean, we would have, I think we conceivably could have missed nivolumab if we had been And we've had this immunotherapy revolution, and so waterfall plots are really just a signal, and maybe a signal we shouldn't rely on too much. We do need to see that survival data ultimately, and to be fair to RedMed, that's what they've started to put into their press release recently, and it looks encouraging.
Yeah, well, and obviously it takes a little bit of time to even know what it is, right? If it's too new.
Yeah. You need to have enough time to run the trial to assess survival. Yeah.
Right. Yeah.
It's just the first picture that you have a waterfall plot, so it's a little bit unfair of me to. I'm not criticizing. It's just that I think it just comes back to this point of seeing the data for ourselves.
No, definitely, and I like teasing through the data at some point. And speaking of that, I'm going to jump back to one of the questions, because we've kind of been talking around it a little bit. So we have two questions around G13, okay? And G13, if you kind of want to like summarize how it's different than just like G12C, because you guys are clearly identifying G12C versus all other KRAS mutants, really. And so what does G13 mean, and how would it be treated? And then I'm going to whether it's a G13C, G13D, and then I'm going to push you a little bit harder, specifically around like cetuximab and a G13 mutation for colorectal.
That might be
a little bit outside your space.
You might be stretching me a little bit, but
that's okay. But at least if you can explain the research part of it, right, from the bottom up, as opposed to top down.
We have been looking at codon 13 mutations quite a lot, so I'm happy to talk about it. I think in the pan cancer, first of all, it's present mostly, I think, in colorectal cancer, codon 13 mutations, and in lung cancer, it's probably about 1 to 2% of cases, we think. In colorectal cancer, I think you mainly see G13D. I can't quite remember the point. I the prevalence within the codon, but I think G13D is the main mutation that dominates in colorectal cancer. Whereas in lung cancer, it kind of comes back to this point of the cysteine being more apparent again, as it is in codon 12, and so there is an even split in lung cancer of about 40 to 45% G13C, 40 to 45% G13D, and all of the rest of them, are sort of rarer alternatives. The biochemistry, and this does influence the targeting and the drug discovery. The biochemistry is different. So, whereas how did I put this into lay speak? This is a challenge here, right? And so
that's okay. I'll tell you what. If you do what you need to do, I will translate.
So the switching on with the nucleotide exchange in codon 13 mutations gets sped up to a greater pool of on-state RAS, whereas in normal codon, the more typical codon 12 mutations is kind of loss of the switching off step. And so they kind of lead to a greater pool of on-state RAS in different ways. And that does have clinical implications. And I think one of the implications for codon 13, as has been looked at in colorectal cancer by the NCI-RAS and Matt Holderfield and people, is like I said before, the potential for upstream targeting. And Matt, when he was at the NCI-RAS, had a particular paper that focused on the role of NF1, which is a really interesting. I guess you guys, have maybe discussed in the past about neurofibromatosis and cancers related to NF1 as well. But it's also present as a sort of non-germline somatic mutation in about 10% of lung cancers, but it's a tumor suppressor gene. So we don't really know what to do with it in the clinic. But I think NF1 mutant cancers probably simulate RAS mutant cancers quite a lot of the time. Coming back to the point of the UK, I don't know who my NF1 mutant patients are just now. I would like to. So codon 13 is coming back to the point. So upstream targeting, you mentioned about cetuximab, and so this comes back to colorectal cancer, and yes, there has been, I think, dominantly retrospective data that suggests if you have a codon 13 mutation, that your cancer might be receptive to upstream EGFR inhibition with cetuximab in a way that more typical KRAS mutations in colorectal cancer, such as codon 12 mutations, have been described as being unresponsive to those drugs. Now, we actually looked at this.
Let me slow you there. Let me slow you there. Okay, because I want to make sure I'm following that. Okay, so are you saying if you have a KRAS G or a KRAS 12 codon 12, okay, and colorectal cancer, right? You're less or more inclined to benefit from cetuximab.
You're not meant to benefit from cetuximab,
and that's on G12, not G13. Is that correct?
This is in G12, yeah, and this is data that goes back. I mean, this is kind of one of the first big steps in RAS precision medicine. Way before the direct inhibitors were coming through, and it was a sort of negative. KRAS was like a negative biomarker for colorectal cancer, so we had these EGFR biologics coming through, and then it was characterized. I mean, not being a colorectal expert, but I think mainly through sort of retrospective assessment of key phase 3 clinical trials and landmark clinical trials, that probably the KRAS mutant patients, which are about 40 to 50%, weren't responding to cetuximab in the same way as the patients with cancers that harbor KRAS wild type. And then the subsequent step with that, yes, has been that story might not be true for the codon 13, the minority with codon 13 mutations, because of the different biochemistry of those mutations and the receptivity still to some upstream signals that isn't necessarily the case for codon 12 changes. And so there has been retrospective suggestion, I think, that EGFR inhibition still benefits colorectal cancers with codon 13. But we were just looking at it in our lab meeting last week, actually, because we're going to get one of our PhD students to look at G13D in particular. And I think the prospective evidence, which is really the gold standard we go by, isn't really there. And it looked like there was a trial of adding, I can't remember the details, sorry, but there was some sort of trial attempt at adding cetuximab back in for the codon 13 colorectals, and it didn't look particularly successful. And I don't think it had, ultimately, it didn't recruit enough patient numbers to make a conclusion. So I think the jury is still out on whether EGFR inhibition works in codon 13 mutant colorectal cancer. The last thing I would add is that, again, with the same sort of approach, combining organoids with some retrospective clinical trial assessment. I have a colleague in the UK, Nicola Valeri, who published a Nature Medicine paper looking at a drug called Lonsurf, which is a third-line colorectal option. And certainly the indication from his team is that Lonsurf and colorectal 13 mutations are worth considering. And Lonsurf may offer efficacy in particular for codon 13 mutations.
Okay, so let me see if I follow what you said. Okay.
Of course.
Right. So G12, okay, mutations have not been particularly responsive to cetuximab. But G13, it was kind of looking like there may be progress on it, but Lonsurf, and retrospectively speaking, which always means the data is always a little murky when you're looking at something retrospectively. But Lonsurf is looking more beneficial in general terms for a patient that has a KRAS G13D with or G13 mutation with colorectal. Did I follow that right?
I don't from memory, I don't think that story went down to the level of 13D versus other 13 mutations.
So it's just the codon, not necessarily the subtype.
from what we know, and I think mostly they are 13D in colorectal.
Yeah, that's, I believe so. I wouldn't want to sign my life away on that, but I believe so. Okay, all right. So yeah, Liz's question answered. Okay, and G13, I know G13 for lung is very really uncommon. Has there been any data or anything that you know around it that you're seeing?
Not too much is the answer. I think I mean, there are epidemiological differences and prevalences depending on where you live in the world. And so I don't know, for instance, in the Far East, if you have a KRAS mutation, maybe you have more chance of a codon 13 change. One thing we see is that even the Ds are all smokers. And so with 12D, as you know, you would see a percentage of never smokers. But with 13, the Ds in our hands are all smokers, which is something that we're following up. Sorry, I've forgotten your question, Terri. I've gone off.
Okay, but that brings up an interesting point that, okay, and I don't follow a script anyway, but it brings up an interesting point. Why is that important? The smoking history, why is that important?
Yeah, I think it's difficult to fully know at this point, if I'm being honest, but it comes back to this fundamental question of, well, I think there's still a little bit of a misperception, for instance, that 12Ds are all never smokers. Now, I know that you've never smoked, have you, Terri?
No, actually, I did smoke some. Okay, I smoked some. Okay, because CDC, anybody who ever smoked 100 anythings over the course of their life, and I certainly qualify for that. So, and I am a G12D patient.
Yeah.
But I also know G12C is typically in people that do have like a fair amount of smoking history, and I know an awful lot of people that have no tobacco history with G12C too. But I guess the question is, like, is it important because it can feel condemning as a patient, but how is it important scientifically, or as far as that's concerned? And
I mean, first thing to say is I completely agree, and we started to, and I'm sorry for going into this trap, but we started seeing trial eligibility that actually includes, whether you've smoked 100 cigarettes in your life and stuff. And I don't think we should be seeing that personally. It can be definitely, I can imagine it feels very condemning in some junctures. And so I think the reason really just for introducing it is really just to get to the heart of the causes of cancer, and using KRAS as a way as a little ecosystem, if you like, for understanding it, because ultimately KRAS is a finite amount of mutations. I know it feels like a lot of mutations, but it is enough for me just about to get my head around, compared to, all of the P53 changes you see and things like that. And so I think the reason it's a bit surprising and worth looking into is that when you have that aspartic acid change, it's not what you anticipate from the benzopyrenes, which are the main carcinogen. Okay,
now you're getting real deep down in the research, and I know that, so that's okay.
I'll go back.
That's okay, but at the end of the day, so really the short answer was that because there's some clinical trials that you have to have some sort of a smoking history to qualify for. That sounds like the short answer.
We've seen at least, fortunately, only one that I can think of, but we've definitely seen one example of that.
Yeah, because to be honest with you, and to be honest with you, that's how it feels as a patient, and it doesn't matter, if I did or didn't, but it comes across to us as though, like, oh well, you did this to yourself. That's really kind of how it comes across, and my personal theory is that it's like it also makes the excuse so they don't have to keep looking. You don't have to keep looking for the real cause, which could be, I don't know, air conditioning or plastics or Chernobyl or something. I don't know.
Yeah.
I'm just grasping at straws. But I mean, it could be something else. And if it's like, oh, but all those people also happen to have a smoking history, then they can lump them in that way. So
Yeah. I mean, I've got one of my respiratory colleagues, what would you call him, pulmonologist, and he said an interesting thing to me because, of course, one of the things we say now is if you've got lungs, you can get lung cancer, and I think that's a very sort of innocent and powerful message. But then he mentioned to me, which I hadn't thought about, that he was worried that it would disincentivize smokers from giving up. And so there is always, messaging is so complicated and nuanced that it's not necessarily,
it's way above my pay grade.
Yeah.
Way above my pay grade.
This is like sort of, Madison Avenue sort of level. You need Don Draper and this sort of stuff. And actually that was in that program, wasn't it? But yeah, I think it's difficult to get a right message for everyone. And so we just need to be pulling in the same direction as much as possible.
Yeah, I know. And so, but at the same time, it's just, that's how it feels. So, okay. So and we will, just so you guys know, we are going to end up going over, because I already talked to Colin and he's
I've still got most of my slides to do.
He ever so kindly, see, I told you, he ever so kindly said that he doesn't have to like run away right at the top of the hour. So warning, I'm still going to hit the questions and we'll probably get to at least some of your slides, but all right. So stick with it. If you have a question, pop it in the list, in the what do you call it, in the chat box. Otherwise, there's no chance we can get to it. And I promise I'm not going to keep you all night, Colin. I promise. Okay. But let me kind of hit some of these things. And again, like, and that I'm, it's my, as an advocate, it's my job to point these things out. And I can promise you my children are less receptive to the oncology community when I'm pointing out things that I'm feeling are not necessarily reasonable. So, okay, so let me ask Lisa's question. She says, if a patient has a recurrence after many years of being stable and off treatment, okay, will they likely retain their original KRAS mutation and lung? That would be first part of the question. And how soon, or would a liquid biopsy through blood potentially detect a cancer mutation if it was either the same or different?
Okay, right. Thanks, Lisa, for the question, first of all. So if it is the same cancer, it's most likely to retain the same KRAS mutation. And if it didn't, there is a small chance that it could be a different cancer. To be honest, if this recurrence was, probably beyond the year after what you thought was definitive treatment for your original cancer, then I would be asking the question about, whether it can be biopsied to make sure it's the same cancer anyway. But yeah, if it's going to be the same cancer, it would be most likely to have the same KRAS mutation. Now, the plasma question is a bit more difficult, because the one thing that happens with plasma that is a bit more challenging is that if you get a negative result from a plasma test, it doesn't really mean very much. If you get a positive result, then it's great, because you know that your cancer has that mutation and there's very little doubt about it usually. But if you get a negative result, that might actually just say that the cancer, it might be a positive thing, because it might just mean that the cancer is not very big and shedding into the bloodstream with its DNA very much. But it might just be that it's been a bad biopsy with a poor quality of sample as well. So if you have a suspected recurrence and a negative plasma test, it doesn't mean that the KRAS mutation isn't there. Unfortunately, you still tend to need to have a biopsy.
And does it matter how long it's been? If it's been 2 years, 3 years, 5 years, 10 years since you've had the cancer?
I think it does, and this is this is the benefit of like, when I was a trainee, I think the real downside to being a trainee is that you do 4-month blocks of each cancer. And so you don't, partly you just don't get to know patients. But also, I think I've got, I don't want to talk myself up too much, but I think I've really got a much better sense of the natural history of cancers that I could never have received from my training, because I've watched, in some cases, some patient cancers for years. And, frequently trainees will come to me and say, oh, I'm worried about progression of this cancer. And then I'll reassure them that I've actually, we've had several false alarms for this patient, and the next scan is often okay. I'm not always right, but you do benefit from that experience. I think now again I'm blethering, and I don't think I fully answered your question, but yeah, I think one thing that I've remembered it now, and one thing that happens is that we'll sometimes get a patient who has a possible recurrence like 5 years later. And I think more often than not, those patients will be more likely to have a new cancer, particularly if they've kept smoking, for instance, because, it is a risk factor for lung cancer ultimately. But when they are recurrences, it is a suggestion to me that this might just be a slow cancer. It might not be something we can cure, but it might be something that we can really reassure patients about and say this might be manageable. And in some instances, those patients have, other health problems. And because of that possibility, we might not even give them any treatment and wait for that first scan just to see if it is slow growing. And then some of those patients come back 2 years later, and I say to them, well, I would have patted myself in the back if I'd seen you today and I'd given you treatment, but here you are with no treatment and your cancer's still okay.
Okay, I would kind of put myself in that particular bucket. Okay, so I've had 5 recurrences over 8 years. And so I think that, I'm KRAS G12D, and anybody who hasn't heard about it, okay, and I'm currently, I have no disease, and I've been 3.5 years with no evidence of disease, but the recurrences all happened previously. I've come to realize that, it's not to say I can't get a new cancer and have a new primary. Okay, that could have any sort of a mutation or an unidentified mutation of whatever sort. Or there's also the possibility that having G12D, I haven't been on a targeted therapy, and so more than likely it wouldn't have mutated into something different, as opposed to like somebody who had been on like a G12C inhibitor, and they had been, then it's, you're inhibiting it, so the cancer is smart and is going to try and work its way around some sort of resistance, some sort of something. No matter, every time I talk about it, I still feel I'm talking about war is what this is. So this is just war, resistance and attacks and targets, and no matter what you do when you're talking about cancer, that's what it is. But the point is that with this G12D, in my particular case, it keeps coming back, but it seems to me I have a type that is slow growing, or at least slow to identify. And then when we've been able to do it, we've been able to like hit it from like radiation or whatever treatment. And then I'm getting back to kind of like ground zero and kind of, yeah. And so I think that there's that as well. And I have never had a doctor tell me that I'm cured. I've never had a doctor tell me that I'm in remission. I've gotten no evidence of disease, no active disease, stable, looking good, but I don't even use that terminology. And so I think that there are people that definitely, I know, in fact, we have people in the group that have had more than one primary with 2 different mutations. One's a KRAS something and one's like an EGFR or something. And then there's other people that have had just like slow growing recurrence that, it's just like cancer can happen in our body. Right. Okay. Now I'm babbling, but all that being said is that there's, there's the timing. There's some that come back fast, some that don't come back slowly, and it could potentially be even a new primary. And by the way, as completely unrelated, here's your PSA for today, your public service announcement. Just because you have had a cancer, you can still get another cancer. So keep doing whatever your other screenings are. If you've had lung cancer, you still get colon cancer, breast cancer, or what have you. So still do those screenings.
Yeah, and truthfully, we frequently observe patients with with two cancers at the same time. It's definitely possible, and it's challenging, and it takes pragmatism to approach, really.
Yeah, we just have to keep going, and you can't give up on yourself, literally. Okay. All right. And I'm going to get back to the questions, and so you have almost no chance of getting your slides. Is there a slide that you
So
don't
shall
have?
I ditch my slides and we'll just have a general discussion
Okay, so
and
that'll
Q&A?
work. Okay, that'll work. I'm
Is that
sorry.
okay? I mean,
Yeah,
I'm conscious that
absolutely.
some people may have wanted to know the G12D versus G12C and biobanking stuff, but we can always do it another time.
I don't know. I don't know. I should have peeked at your slides and I didn't, truthfully, full disclosure. So,
Should I do them quickly I do the biobanking stuff?
okay, well,
Mm.
all right. I'm sorry. You want to go? I'm sorry. Go ahead. You put all the effort into putting together a slide. Go for it.
Okay, I will do the biobanking stuff because people can read the paper for the G12D story if they're
Okay.
interested. So coming back to the main take-home message that I think I said in this slide, which is that we need to have patient-based models to define the best combinations and selection strategies. So that's what we're really trying to generate here. Again, taking this unenviable position of having so many patients and trying to create as much data as possible that will filter down into some hopefully meaningful translation. And this takes years. But, we set a biobank up there where we can take patient samples and biopsy samples, including at research time points. And so that would be sometimes asking patients within reason to think about an extra biopsy when it wouldn't necessarily be needed for the clinical care. And so we've done that on occasion in the right patients. And this sort of effort, unfortunately, for this, it takes two hospitals, takes all the pathologists involved with the different cancers, takes the oncologists involved with the different cancers, it takes the technical staff on the ground, including the biobank staff. So it seems like it should be simple, but it's actually a massive undertaking. And so what we can do in our protocol is recruit patients who are affected by cancers with RAS mutations, epithelial cancers. So these are the three main that you guys all know about, but you'll see that so far we're focused on lung for obvious reasons. Now, we've recruited to use of any spare tissue, plasma, or data, 356 patients so far, and that would be, just pushing over 100 over every year for over 3 years now. For most of these patients, we do just have maybe flimsy samples that might be left over from their diagnostic biopsy. We have their data that we can analyze. And a significant minority will either have frozen tissue for some of the techniques we do, but also coming back to this point of patient-based models, we've done 27 patient-derived xenograft attempts. So those are mouse models based on the patient biopsy, where we generally inject those tumors into the flanks of mice and see, first of all, if they establish and stay there, and then if they grow, and then we consider treatment. And so this is a breakdown of RAS mutations we see in the cohort, and it's roughly what you would expect for an international population as well. What's, I guess, quite interesting about what we've seen so far with these models that we've developed, and we are treating these with interesting drugs and combinations, I can say, but unfortunately I can't tell you too much more detail just now. But this is probably selection bias, but we do have a number of G12C models that we've seen. And what's been nice about it is that we actually have a G12C model that represents complete treatment naivety. So it's a model that's been derived from a patient that's had no systemic treatment. And then we have one or two models that have been derived, for instance, in someone that hasn't had a G12C inhibitor yet, but has had immunotherapy, so a different stage of treatment. And then we have, at least a couple of models that have been derived from patients that have moved through the main treatment options of both G12C inhibitors and immunotherapy. And from this patient, who sadly isn't with us anymore, and she was incredibly, we're indebted to her, and she was incredibly involved with our research, and she actually underwent biopsy before and after G12C inhibitors. So we have 2 models derived from one patient before and after sotorasib from our routine care. And that's going to be really an invaluable resource for the future. Now, we have failed models as well, so tumors that we injected into mice that for whatever reason didn't establish, and it might be a little bit like the plasma thing, that they're just not oncopotent enough, if you like, to be able to establish themselves in mice. It might be due to other factors as well. And then we give these mice about a year to see if the tumors develop. And so these are all the models that we're still waiting to see for. You can see, hopefully, that we have lung cancers, of course, but we are doing more in the way of colorectal cancer models as well. We have both early and late stage tumors represented. We'll continue to do, again, always within reason, more and more models so that we can try and really get the key signals from all of these drugs coming through. I mentioned flimsy samples that you take in the health service, in every health service, and that's usually done with formalin-fixed paraffin-embedded biopsies. But of course, one thing to highlight is that we have these really exciting and quite labour-intensive just now new techniques that we generally refer to. You probably have heard of spatial omics. And so the way to really reduce resource for these cutting edge techniques is to produce these tissue microarrays where you have all of these, in this case, KRAS mutant early stage lung cancers lined up in one slide next to each other as little cores here. And the advantage of these techniques is that you can look at all of these different markers of, and mainly in this instance of the immune system, just in one slide across multiple different tumors. And this is stuff that we were never able to do, I think, even 5 years ago. And so we've made, again, we're working on this, but we've made 2 KRAS mutant slides like this from lung cancer. We've made 1 KRAS Wild type slide like this from lung cancer. We've got whole genome sequencing aligned to these tumors as well. And that's really going to take us to a data set that is, I think, internationally at completely the cutting edge of what we can do in terms of omic profiling. So this is clearly research-based profiling, not health service-based profiling. And these are the sort of pictures that you can get from these techniques. And so, just now I have to say that they are just pretty pictures of tumors, and we don't know what the stories and messages are from this analysis yet. But, in green, what you can see is the epithelial cells, red mesenchymal cells, and blue, the DNA from all the different cells. And then again, just trying to squeeze as much translational information out as we can. I think to understand the prognosis of different codons, different point mutations within individual cancer types, unfortunately, we probably need to collect real-world cohorts of thousands of patients, maybe several thousands of patients. And that's, one reason that for this project in particular, we collaborate as much as possible with international colleagues, because even with this collaboration with fantastic colleagues, our effort to do this has only reached 800 patients. So we'll probably, with our first publication, be able to comment on the main mutations, such as G12C, D, and V, and how they respond to immunotherapy and other things. But we're not at the sort of level where we can tease out rare mutations such as codon 13 that we were talking about earlier. And this is really the peak of what we've been able to achieve with the biobanking, Terri. So again, a patient we're hugely indebted to, as is often the case with patients who live for longer than we might anticipate. He lived for several years until he died in 2022. And he had a G12C mutation, an STK11 mutation, and a PD-L1 high tumor. And actually, when we opened the biobank, we consented him to it after he'd received chemoimmunotherapy and done well with it. And then after he'd received standard of care sotorasib, that's when we took this adrenal biopsy that you can see here from this lesion here, and we derived the patient-derived xenograft, this mouse model here. He also had circulating tumor cells in his blood at this time, which is quite unusual for non-small cell lung cancer. And the patient and his relatives were kind enough to allow to undergo post-mortem. And this is kind of what I increasingly describe as cancer donation, because we can do organ donation for cancer patients, but we can do research with those cancers if we're organised, and also we do the post-mortem quickly enough. And so we have, I have to say, scores of samples from different cancer lesions within this patient's post-mortem. One of the things we're going to look at is, for instance, some cancer lesions with immunotherapy or KRAS inhibition. Some were responsive, whilst at the same time some weren't responsive. So we're going to look at the intra-patient resistance story for this patient and one of the other patients who's undergone post-mortem as well. So I'm going to stop here and just say what this biobank is all about, which and just remind everyone. So I'd like to think we're doing as well, we're doing relatively well with the trials that we're running. Like I said, we still need to do better access to G12D and pan-RAS inhibitors in the UK. The biobank itself is meant to create signals for that reverse translation so that we can move back to the lab to look at the mechanistics and understanding, and then back to the clinic again. And it should really be a space for collaboration with everyone. It is very resource intensive, and so it's a big project that I've spent a lot of time over the past 3 to 5 years developing with great colleagues. We want to move past this sort of data just confirming the traditional cell line data and stories that are typically published from many labs around the world, and being a resource for colleagues around the world. But most importantly, and I think some drug companies might be thinking this, they don't necessarily say it, sometimes you can just go to a clinical research organization and just pay someone to use these models and look at your drugs. But I think the powerful thing that we have to offer is that these models remind us of the patients that we've looked after. We really want to invest in these models and make sure, whether it takes 2 years, 5 years, 10 years, 20 years, that we do justice to the patients that have donated so much of their time for us to be able to do this work. And so we'll just keep going.
That's really powerful stuff. And so when it comes to the biobank, right, I don't have to be dead. I can actually give you permission to take a piece of my tumor or take whatever it is that you need biologically to do that sort of a study for your biobank.
Yeah, and I think that's one of the great things about here is that the biobank was a really, really strong setup even before I arrived in Manchester, which was 7 years ago. And so, for instance, I showed you a face in my slide, and I didn't introduce him, but Matt, one of my colleagues, he has both a nursing and a scientific background, and so he actually consents all of the patients without the medics having to do it, and that's the sort of thing that can make a huge difference in the ground. Asking medics for their time, as is challenging, even at the best of times. And so to have a dedicated member of staff that's just sitting in as many clinics as possible and doing that consent really allows you to move forward. But yeah, the model of the biobank here is that they sort out all of the governance and ethics for you as much as possible and keep abreast of it as much as possible. And then after that, they just have a common consent form, and you just need to submit a relatively simple application to say what research you want to do and what resource you have to do it.
Do patients get a copy of the information that you obtain on them individually?
Yeah, I think that's a question that's still an active discussion, if I'm being honest, because I think we're only just starting to see results because this takes so much time. And so, if I were to go into the sort of G12D versus G12C story that we published earlier in the year Terri, or in the last couple of months, it didn't really involve that much of this work, if I'm being completely honest. And I think when we move into 2025, that's when we really need to kind of, I think it's an upfront conversation, isn't it? Do you want to know what the results will be from the work that we might do with these mouse models? What should we do in the instance that you don't survive your cancer? Should we update your relatives? I'll be honest and say that we've tended to keep in touch with particularly the patients and families that have undergone post-mortem, because obviously the communication is essential for that. But not necessarily all of the patients that are still alive, for instance, and we've developed mouse models from. And I think you've really hit on something there that we need to sort out in 2025.
Yeah, I
know you.
That. Yeah.
I know you would definitely advocate for us telling everyone, and we need to at least be giving them the option. And I think we do, but I don't think we're absolutely clear in what our conversation is for that discussion and how to standardize it.
Well, and it's kind of, by the time we all figure it out, a new latest and greatest will come along, right? And so there's that part of it as well. But yeah, I do think that people should know. And it's like, if you guys pulled information from all I knew is it wasn't KRAS G12C, and I found out later, like you did find out that person had STK11 or whatever, it would be kind of nice to kind of know as an individual. And it's just kind of like empowering. And so, but that's like a conversation for another day. So if I'm in the United Kingdom somewhere, how would I be able to participate in the biobanking activity?
Yeah, and unfortunately our reach, and this is the advantage of having such a big centre, our reach only extends within Manchester. I think even, I think this work probably wouldn't be possible in every other centre that I can think of in the UK, because we have that combination of a heavy research focus, but also a great deal of patients. And so it's achievable as a single centre. It's difficult to fully know, obviously, having not worked it everywhere. But, I'm sure that centres that you guys are very familiar with, such as MSK, such as Dana-Farber, MD Anderson, are doing similar work. It's just difficult to know exactly how they're approaching it. Do they have that RAS focus, or is it more disease-based focus? And those sort of questions that come into all of it.
Okay. Yeah, I don't know. All of a sudden, Caitlin showed up here in our, I don't think she's not backstage. It's okay. I'm going to ignore it. Yeah, well, and there are different places. We did a thing at Moffitt not that long ago, and that's one of the things that they're doing there as well. And I know that they're across. And so even if you're not in Manchester, the point is that you can participate in doing this for the biobanking. So let me get, thank you for all of that.
Sorry, I'll just interrupt briefly, but I should do a little plug for TracerX for anyone that doesn't know about it or hear of it. So beyond this, TracerX is really the sort of landmark lung cancer research UK study that I think trailblazed in terms of describing heterogeneity of lung cancer and other cancers now as well. Part of that program called Peace was what led to these post-mortem samples as well. So if you want to participate in fundamental biobanking and biology that might not be so KRAS focused, then definitely that is possible in the UK. I think for the RAS Biobank, it's just more Manchester based.
Okay, well, yeah, all I know is by the time they get it out of me, I'm just glad to not have it in my body. So do what you want with it. Just hopefully they can do something good with it. So it's my personal feeling. All right, okay, so I appreciate you running over, and I'm going to be, because this is your evening. And so we got questions in here though. So, but thank you for going through that. And I'm sorry I delayed on
No
going through the
worries.
biobanking part of it. So, okay. All right, I'm gonna hit these, and I'm gonna keep you brief so you can get out of here and go spend time with your family. Okay.
Okay.
So just answer them. We'll go with them. Okay. So Steve is asking the question. This is Stephen from Hong Kong, and he was here up in the middle of the night. Oh my goodness. Well, thank you for joining us. He's here on behalf of his wife. He wants to know about any advance on KRAS G12R research and any clinical trial efforts across Europe.
Yeah. Hi, Stephen. Thank you for joining in the middle of the night, and I hope your wife is doing okay. Now, G12R, unfortunately, it's one of those mutations that kind of sits in that category of not common to lung cancer, so I'm afraid my expertise doesn't extend very far. Is it pancreas cancer, did we say, Terri, or did we not know? From Stephen.
It says that it's lung cancer.
It says it's lung cancer.
It says lung
Okay.
cancer, yeah.
So
And so, yeah, it's really crazy. And the funny thing is that
is
I've
rare.
seen a number of people that have a G12R lately. And
Yeah, that is a rarity. And I think maybe if we went back to our sort of patient-derived xenograft models, we did maybe even have 1 or 2 G12R attempts in there. Now, it's more common to pancreas. From memory, I do think the Showcat lab, who originally described the G12C first iteration inhibitors, have described a possible putative drug for G12R as well. I'm not sure how advanced that is in terms of development towards the clinical setting. But I guess one of the hopes might be that given the RAS multi data, the pan-RAS inhibitor data from RevMed seems to work best in codon 12, that G12R, obviously being a codon 12 mutation, might benefit from the Revolution Medicine pan-RAS inhibitor, or for that matter, pan-KRAS inhibitors that are coming through that we've seen less clinical data from so far, including the Boehringer drug.
Okay, and so there are, I know that there's those RevMed trials across Europe. I don't necessarily know all the locations.
Yeah, so the drug is I would be surprised if there wasn't a trial of RMC 6236 in Hong Kong. But our other pan-KRAS inhibitors, sorry, it's so difficult to remember all of their numbers. But you still, as we do with any KRAS mutant lung cancer, want to make sure that you've exhausted normal treatment options, whether it be surgery or radiotherapy in the more curative setting, or chemo and immunotherapy in the advanced setting.
Yeah, it says that he said that, thank you, she's stable at the moment. So,
Okay.
Obviously, obviously my hope is that she remains stable and in front of this, and in the meantime, the longer, you have to play the long game when it comes to cancer. And it just seems like the longer we can stay at least in front of it, we're not getting further behind and the research is moving forward. And so that just seems like where we're kind of at.
Yeah. The developments, I think they always seem slow, don't they? But relatively, they're moving at pace. Nothing was happening 10 years ago. Even when I started here, I think I could go to a lung cancer meeting and KRAS was barely mentioned.
I've only been doing it not 5 years, and it used to be KRAS and BRAF, and then there was just nothing at all. And then, then things started happening, 2 approvals and whatever. Okay. Any new trials on G12V? It feels like we kind of exhausted a lot of it. You're not going to be particularly familiar. I'm just going to answer for you. You're not going to be particularly familiar with G12V because you've already talked about how you guys are just looking at G12C particularly. Is that a fair thing, or you already know? And I'm just being rude.
No, not necessarily. Actually, I think we're interested in all of it, and it's just that the models we made happen to, I think, just partly because we see treatment patients more often, happen to be more prevalent with G12C, just now. But we do have a bit of a focus that we're developing even more G12D and G12V models, Terri, and so that some of the preclinical models we have, I have to admit, are less G12V orientated in cell lines, because we look at tumor initiation and we switch on KRAS mutation without any of the co-mutations, which is always an interesting thing to do, just to see the sort of pure effect of a KRAS mutation and how it affects normal cells. But G12V, as you probably know, I think a putative inhibitor has been described for that now by Revolution Medicines as well. And again, it comes back to the possibility of its vulnerability to pan-RAS and pan-KRAS inhibition.
Okay. All right. I'm just going to take the next question up here. It says, I'm from Jerry. I have G12D. I'm assuming it's lung. I didn't say. I have KRAS G12D. After successful treatment, put on Imfinzi that damaged my thyroid. I've read that thyroid damage can be short-term, and others say it's permanent. And what are your thoughts on that? Bonus points, yeah. It says if you don't answer, everyone is different.
Yeah, I think yeah, and it can do both ways. So immunotherapy can either lead to overactive or underactive thyroids. It's generally perceived as a more permanent side effect, if I'm being completely honest. And so I hope it's being managed okay, and the symptoms from it are okay. I think we're probably still need to do a little bit better at warning patients up front of these long-term toxicities. I think, we are trying to adjust to it, and an increasing number of patients we have that do have long-term toxicities. I know we've talked about this in the past, Terri, and steroids are a big issue that we need to move forward with. Although they don't necessarily apply to thyroid toxicities. And so, yes, I'm afraid there is a chance that it might be a long-term side effect for the rest of patients' lives. But usually one that should be manageable with the right care.
Yeah, it's tough. It's tough. And I mean, I get it. And my heart breaks because, I mean, it used to be, you guys, if you went into any sort of cancer like this, it's like, our life expectancy was in like, is a big bonus when we got past days into months. And now that we're living years, now long-term even has a place in the discussion, whereas it used to be, well, we'll see if we can, make it, to the end of the month. So I get it.
And this is a balance, and it does need articulated well. Before immunotherapy, we were quoting average survival of around a year, and now we're quoting it at 2 to 3 years. And so I think nearly all patients accept these potential risks, but we need to just not be complacent and make sure we always remind them of the possibilities. In the past, when it was just chemotherapy, I wouldn't push patients into treatment because it had limited benefit. But now, if I see a new patient, I do tend to say to them, this is a good treatment. There may be side effects, but it's difficult to advise patients not to take it usually nowadays.
Yeah, I get it. I get it. It's not an easy thing, but at least we're living long enough. Do we have side effects? I guess, there's that part of it as well. All right. Oh, unfortunately, Stephen, I'm following up with his messages. He says there's no KRAS trial in Hong Kong, and it looks like the pan-RAS trial, there's hope. I hope you do find some hope, Stephen. Okay, I'm gonna hit you with this question that John is asking here, though I probably will contribute to the answer. It says, has there been any studies that look at pan-RAS or pan-RAS inhibitors in combination with repurposed drugs? And he identified as ivermectin.
Ivermectin. Okay. I don't know. Sorry, there are so many drugs. I don't have specific experience with ivermectin. Now, the
Well,
drug
or even any
repurpose,
repurposed drugs when it comes to PNRAS or PNRAS inhibitors. I mean, that's
yeah, yeah. And so we do, I mean, the drug repurposing thing, I think, is very interesting for anyone that doesn't know about it. You know, you have hundreds of drugs that are already FDA approved and Europe EMA approved that we don't necessarily know they might not benefit cancer. And there's, as you guys will probably know, there have been a multitude of different stories in the past of things like metformin and other drugs that we commonly use potentially having anti-tumor effects. And some of these stories work out and some of them don't. But the point is that we know the toxicities of these drugs. We know that they're clinically safe, so that the regulatory and trial structure and hurdles that you need to jump over if we found a hit would be so much easier to deal with. Now, to come back to the question, I would probably just, I'm not sure it's necessarily been looked at in combination with pan-RAS inhibition. I know that there's no question that companies and their R&D departments will be looking at this, but I'm not necessarily privy to their data. I have a very good colleague called Sylvie Vicente, who works in Pamplona in Spain, and he published a very nice story in a journal called, I think, Molecular Cancer it was, in the last couple of years, looking at drug repurposing for MAP kinase inhibition, but ultimately for G12C inhibition. And he did find that a multi-kinase inhibitor called midostaurin actually came up as a real key hit that we have actually tried to pursue as a sort of combined G12C midostaurin trial. And unfortunately, we haven't been successful to take that idea off the ground in the clinic, but we will keep trying because sometimes it's just about a change in the landscape and these combinations become a bit more plausible or desirable as far as strategies are concerned for other partners. We've got our own actually drug compound screen that has over 200 genes that could potentially be repurposed, and it's a very straightforward thing to do if you have the facility to do it. And so it's definitely a hot area of research. Every way of looking at KRAS just now is likely to be being explored like that, and there will unquestionably be more stories in the future in terms of combinations with existing and new inhibitors.
Okay, it was a great answer because it gives us more confidence that you all as medical professionals are looking at it. And at the same time, a lot of times when we've got new drugs that are coming out that aren't even approved yet and they're still in clinical trial, they're not going to be looking at it in combination with something else unless they've already looked at it in a lab. They're not going to just go dumping it into human beings. And so that's the other end of it.
I mean, I could give you another example briefly, Terri, which is that there is and this was a G12D story from the States actually, but unfortunately it was in a tiny number of patients. And so we really don't know if it's real or not, but there was, there is 2 or 3 kind of lines of evidence to suggest that hitting a part of cell biology called the proteasome might be of particular relevance to KRAS mutant precision medicine. And so there was a sort of Cold Spring Harbor report of only about 12 patients that said patients that had G12D and mucinous cancer. I mean, 2 or 3 of those patients had an exceptional response to proteasome inhibitors. But of course, it comes back to small numbers of patients, but also it was a waterfall plot, right? And I don't think it was necessarily a durable response even in those patients that responded. But I guess the point I come back to is that because we use bortezomib in hematological cancers, we had a young patient with a mucinous G12D cancer where we've exhausted all possible options. And so we managed to justify internally to try bortezomib. And unfortunately, it didn't work. But I'm glad, I think we were all glad that we tried. And so there is sometimes I think in the right clinical setting, immediate potential with these possibilities as well.
That was a good answer. Well, you have been more than generous with your time. And so I appreciate your staying in so long to handle just my nonstop level of questions and the amazing questions that we've had from our patient community, from the amazing KRAS Kickers that we've had. So I'm just going to thank you for being here and for being so generous with your time and for answering the questions so much. I really appreciate you and all that you guys are doing. And it's always a pleasure whenever I get an opportunity to like run into you at some particular event or whatever. So I'm still trying to finagle a way over there because I keep understand you guys play football or some such thing over there.
Yeah, the weather's pretty bad, to be honest, Terry. Yeah, no, there is soccer, as you guys call it.
Yeah.
But yeah, I actually prefer the NFL to soccer, I would probably say. But yeah, could I just say what an incredible advocate you have been for a long time now on behalf of patients and relatives. It's been, you are a trailblazer, and I hope you have an incredible Christmas, and it's going to be a pleasure to see you again in 2025.
Sounds good, Colin. I appreciate it so much. Thank you so much, all. And we're going to close this out for this round, and we'll be putting this out online. And thank you again, Colin. I look forward to seeing you, and have a Merry Christmas and Happy New Year. Hope to see you in 2025.
You too. Okay. All right. Bye, everyone. Thanks. Bye.